Oh, you don't? Did you apologize? No one's there. Oh, gosh. Ready?
The broadcast is now starting. All attendees are in listen-only mode.
Welcome. This is Peter Lee, the Executive Director of the California Health Benefit Exchange, and you've joined us for a webinar to discuss, provide background, and get your input into issues with regard to provider network issues for qualified health plans. This is the second of 3 webinars we're holding. At our board meeting on July 19th, we released a 263-page document outlining recommendations in a range of issues with regard to our qualified health plan. We had, I think, a very good initial discussion, but we all recognized we needed more time to hear from folks throughout California, engage in discussion, which will provide input to the exchange as we then sharpen and make final recommendations to the board to be considered at the August 23rd board meeting. I'll do a couple other reminders, then hand the ball to Andrea to walk through the material. A couple things as sort of housekeeping is we'll be referring to slides that are before you. Those same slides are available on our website in case your system crashes and you need to be on phone and not on the webinar. There will be a third webinar on August 1st from 8:30 to 10 on the issues of quality and affordability of qualified health plans. And this webinar, while originally scheduled to be an hour, we are ready to go an hour and a half if we need to. And we want to warn you that, not warn you or invite you to stay with us if we need to stay until 6 o'clock. The call we had earlier this week used and needed all of its hour and a half. It was a very robust discussion. We encourage people to use the chat feature to type out your comments and questions as we go through, as well as to raise your hand. And with that, I would remind you, again, that we are creating what is really the example of how to do an exchange right for the nation. We're trying to be thoughtful. We're trying to sort of strike the balance of being at the cutting edge of what any plan is doing or exchange is doing around the country, but also recognizing this is a big deal. It's a big deal for consumers, for providers, for health plans, and we very much appreciate you taking time out of your days to help us craft the best recommendations. I'm happy to note we have with us today Kim Belche, one of our board members. Bob Ross should be joining us shortly. At our last call, we had both Paul Fear and Diana Dooley, and we look forward to having a number of board members at our next call. Given our open meeting rules, we call this our paired choice process to have 2 board members per. But Kim, thank you very much for joining us, and we have encouraged Kim to weigh in with questions and comments to us so you can get a sense of issues that she may have on her mind as well. So Kim, again, thank you for joining us.
Glad to be here. Thank you.
Right. So with that, I'll turn it to Andrea to introduce the team. And then what we'll be doing when we walk through the issues on the slides is we will pause after each issue to get comments and questions and not wait till the end. We're going to do it step by step. We think that works so people can know what to comment on. It does mean we often go back a little bit because if people think about comments, you don't lose your chance to make a comment, but we'll try to pause after each topic, go to the next topic, but don't feel you lost your shot. And be patient with us to make sure we get people's comments considered. With that, Andrea.
Okay, thank you, Peter. So first I'd like to thank my team who helped work on the report, and that includes Leah Morris, who's here with me today. And she especially worked on essential community providers as well as provider network adequacy. And Amy Krause, who was embedded with our group, who is a full-time employee of the Department of Managed Health Care, provided a lot of input, and Lisa Howard, who provided a great deal of support. And of course, certainly our very important consultants, Sandy Hunt and Susan Murky, and Emma Fu and others on her team have provided invaluable technical and expert input into the report. So don't forget to join in if you're interested in the issues that we're going to be discussing on August 1st at 8:30 a.m. And those are the quality and affordability sections of the QHP report. And we welcome your participation at that time. And just as a reminder, we're requesting written comments be submitted through our website. If you want to use the form, that's great. If you don't, that's fine too. But we have created a QHP specific input form, and it's on our website, and we're requesting those by close of business on August 6th. So thank you in advance for providing written comments. So turning to, we're going to cover two of the briefs in the large report, both relating to network issues, and we'll start with provider network access. So this is the entire network, whether it's HMO or PPO, that a QHP bidder would be submitting, hopefully early next year as part of their bid. And we looked at what should be the network access adequacy standard that is required to be as a condition of QHP certification. We looked at 3 different options, and just to be brief, since this is not the first time you've seen this slide, we're recommending to the board that they adopt option A, which is the regulatory requirements of the bidder's current regulatory agency, which means that if it's a CDI plan, they would use the CDI regulatory requirements. And if it's a HMO plan, they would be bound by the Department of Managed Healthcare regulatory requirements. Now, I do want to say, as an aside, that we have been having ongoing meetings with the regulators. We are very fortunate to have a close relationship with the regulators, and I've been reassured by the regulators that they are building and are intending to have at the ready a robust ability to review geo-access style reports and measure network adequacy by provider type. So, do you want me to go through all the provider network adequacy ones?
Yeah, let's do the provider network adequacy pieces.
There's only 2 pieces.
There's 2 together, and then we'll pause after those 2, okay. Andrea. That's a great idea.
All right. So going to the next issue of who evaluates provider network adequacy, I guess I kind of jumped the gun and put those together. There were 3 options. Should we let the regulators do it? Should we do it? Or should we require more frequency and more detail in geo-access reporting? And as you know, we're always kind of balancing meeting the standards and wanting to have robust networks and adequate access against plan burden, especially in year 1. We want to encourage, not discourage, California's health plans from bidding to participate in the exchange. So in light of that, and in light of the work that we've done with the regulators, we are recommending to the board that the regulators hold the responsibility for certifying a QHP bidder's network that it complies with the applicable network standard. And again, I have been in discussions with the appropriate people at both CDI and DMHC, and have been assured that they are going to have the capacity to check everybody's network, run it against the standards, do the mapping, and verify whether or not a QHP bidder's network complies with today's standards. So with that, I'm happy to invite questions or people who call.
Or make comments.
Or make comments. Yeah, certainly not questions.
Either typed in or spoken. The other thing that I would note on this is that DMHC has taken quite a while to develop, with a lot of consumer and other input, a provider adequacy standards that are just now sort of taking root. And we look at and same thing with CDI, building out what they've been doing, and we will be evaluating this and see how it works in 2014, 2015. As with everything we do, it's a learning QI process, quality improvement oriented process. And so this is where we would start, do this for the first few years, see how it's working, and have us collectively kick the tires.
And just as a follow-up to that, I would say that just because of, we're recommending that CDI and DMHC do the initial certification of a QHP bidder's network, does not mean that the exchange is going to relinquish any ability to hold a QHP bidders network to the terms of the contract. We're anticipating having a contract between the exchange and each of the QHPs that we select, and that contract will require them to maintain network adequacy. So it's not just a one-shot deal. If one of our enrollees calls in and says, hey, I really can't get access to any pediatric subspecialist for my child, we will absolutely have the ability to bring that to the attention of the regulators, require our own reports. We're not precluded from following up on individual network adequacy issues as they might arise in the future once a QHP is certified.
So we have a number of comments, and I'll read them out. And just so people who are not on the prior call, we are a transparency organization, and so we actually name names of people who make their comments. So I'm going to start with a question from Brett Johnson, which is, does that buildup of the ability by the agencies, meaning CDI, Department of Managed Healthcare, include any resources to verify that the information reported on plans geo-access reports? And the thing that, I'll toss this to Andrea, but I would note that many questions that might come up might be questions that in some ways are more appropriate for the departments, for the regulators themselves. And we will, what we've noted in our discussions with the regulators is they have stated their interest, commitment to do their job, which is assuring network adequacy under their standards. And the extent to which they have adequate resources, not adequate resources, is in many ways an issue for us with them, but also for many of you with those regulators. So with that, Andrea, do you know a?
Yes. I think that what Brett Johnson is asking about here is, do the regulators dig underneath the purported provider network that is represented in a geo-access report? Certainly, I know CDI a little bit better than DMHC, but certainly CDI, if CDI had any reason to believe that a network provider that was included on a provider networks panel was not part of a network, they certainly have the capacity, they certainly have the statutory authority to challenge that. Would they want to undertake a sampling of a particular network to require that there are actually provider contracts to back up that panel? I think that would be up to them, and certainly they have the authority to investigate that under their current complaint authority. So if there was a provider who said, hey, I was included in Blue Shield's panel, but I'm not actually on that panel, they have lots of statutory authority to investigate that and require the plan to prove that they actually have a provider in their network.
And I would note that the exchange, though, will be a resource for this, is that if we get complaints through the exchange's service center of, you said this doctor was in the network, they're not available, we will refer those to the regulated entity to say it appears folks that were listed as able to take patients are not, et cetera. So we will absolutely be working in partnership of using those sorts of data points for both regulators to inform what they're doing. Okay? A question, yeah, it's from Beth Capel, is where in the insurance code does it require CDI products to provide access to medically necessary specialty care? Out-of-network care is not affordable for consumers making $10 an hour, which is about the 133% of federal poverty level.
So that's in the California Code of Regulations at Section 2240 at SEC. And there is a specific regulation that requires, that sets time and distance standards to medically necessary specialists. So, but again, I think the important point is this: we will not develop separate regulations what are on the books in the regulations. So some of these we need to tease out, and there may be differences in some cases between CDI and DMHC. Our recommendation is where they are not identical, we are following, if it's a Department of Insurance regulated plan, we follow that department's regulatory structure. Right. If it's a DMHC plan, it's that regulatory structure. Right, and in fact, there is a difference for specialists. DMHC doesn't have a time and distance standard for specialists, and CDI does have a time and distance standard for specialists. And again, we've talked about this with the regulators, and they are prepared to follow up on any issues that come up with our enrollees that relate to network adequacy.
Okay, so Rachel McLean notes a twofold question, which is, would California consider only having one regulatory agency for health plans, just to keep it simple? And related to that, are there many plans that will be regulated by both CDI and DMHC and thus have to adhere to two different standards at the same time? It seems confusing. Well, this is speaking to broader regulatory oversight issues. It is not the call of the exchange to say there should be one regulatory oversight. I would note that there's been, over the last 5 years, and I've been out of town for a couple of years, but there's been more and more movement towards the two regulators being more and more consistent. And I think that's something that the Department of Insurance has looked to. So there's movement in that direction. I do believe that plans are only regulated by one or the other. And
yes,
so
they're mutually exclusive.
They are mutually exclusive. Okay? Will the access, and this is from Mike O'Day, will the access metrics and network data reporting be required to be broken down by pediatric child versus adult population?
Not at the outset. The standards are for primary care physicians versus specialists versus hospitals. Those are the category breakdowns right now in both regs on the CDI side and on the DMHC side. So they don't necessarily, at the outset, require a network to show that they have enough pediatricians or child-only population. And remember that year one, the exchange-specific population is an unknown quantity. So there wouldn't be any way for, Blue Shield to be able to show access to a certain number of children in the population because they don't know how many children they're going to have year one. So they'll have to use a, kind of garden variety commercial population year one until we know what the exchange population demographics are looking like, which would be year two.
So from Megan McCammon is, does the Department of Insurance have any cultural and linguistic competency standards for provider networks? If so, are they comparable to DMHC's?
I have to confess that I haven't memorized the entire regulation for CDI. I think they do, but I'm not 100% sure. So if you don't mind, can I get back to you on that?
And also, though, this is a foreshadowing, separate from the network adequacy standards. One of the things the exchange is looking at doing that we'll be talking about on the 1st with regard to quality and affordability is we are considering, in addition to the accreditation requirements, and accreditation often gets that cultural linguistic competency, potentially requiring all health plans in the exchange to have completed the Evaluate RFI, which is a request for information that has a segment specific to what the plans are doing in terms of cultural linguistic competency and addressing disparity of care issues. So I'd encourage folks to look at that information. We're going to be posting that RFI on our website so you can look at it. And that's a place where we'll also be reinforcing our shared concern to make sure that access is available.
Right. We've spoken about the Evaluate tool that we're going to be recommending to the board to use, and Section 1.7 requires the type of information, Megan, that you're asking about to be gathered by the plan, which is not only to get the ethnic and racial information about the population they're serving in order to identify ways of reducing health disparities, but also on the other side to get information about the providers who are in their networks serving the population to find out what kind of racial and cultural and linguistic competency they have, what languages they speak, and things like that. And I would say if there's anybody on the line from the Department of Insurance who might know the answer to Megan's question about the regulation, feel free. But I think that we can get back to you on that.
And also, again, I do want to make the point that by relying on the regulators, we're relying on the regulators, which means you, as advocates or as partners, need to work with the regulators to hold, and I say this in the best possible terms, just as you hold our feet to the fire to be good purchasers hold their feet to the fire to be good regulators. And so that's one, dealing with them directly, we would encourage. Last two, we're going to take two more comments and then move on to the area of essential providers.
Sure.
And then we can come back to these. So the first is from Ann Donnelly, is where standards differ between CDI and DMHC, will the exchange make that information available to consumers as they make plan choices? And I think we will absolutely, it's a great suggestion. This is a good example of where, give us your comment on how you think we should do that and where the differences are meaningful. We want individuals to make informed choices. And some of the questions that I think we'll need to weigh is how much information you give to make an informed choice. If you think there are elements that are critical that would inform choice, that are a bigger issue for them, that rise to that level, we welcome those comments. And that's sort of issue of a core part of the board's adopted mission is to enable informed consumer choice of plans and providers. How much information and what's stored is something we'd welcome your thoughts on. Okay. From Patrick Pine, and if already addressed, no apologies are ever needed here. What about pharmacy network versus provider network? How is that being addressed? So does either CDI or DMHC have network adequacy with regard to pharmacy access?
They do not.
They do not. Okay. So this is an issue where we will have formularies, but not necessarily pharmacy adequacy network standards.
That's right. And, I think that the threshold question is there really ever a real issue about access to pharmacy networks? That is not one that I've been made aware of. It's kind of in the category, if there's not a problem, you don't really need to address it. I'm not aware of consumer complaints regarding difficulty in accessing pharmacy. Now, that may be true in rural areas where there's fewer pharmacies, but with the advent of broad-scale pharmacy benefit managers and pharmacy and PBM contracts with plans, that's typically not an access problem.
So we have one last comment here, last question, and then we're going to go to essential community providers, is from Brett Johnson, noting that I made the comment that regulators may use exchange call center complaints regarding networks as a source to inform them of potential access problems. And there's a question, will providers be able to submit network complaints to the exchange call center or other staff, or will that function be served by the quote-unquote stretched regulator resources? Similarly, the question, will exchange funding be going to regulators to support the added volume from exchange plans? Just to be very clear on this, and one, we are working in very, very close partnership with the regulators. But having, for instance, if we have 1.5 million new covered lives in the exchange that are DMHC enrollees, those plans are paying fees to DMHC. And they are regulated by DMHC, and they're expanded as part of DMHC's job or CDI's job. So my quick answer, protecting our purse but also being appropriate in terms of our role, is no, the exchange won't write a check, because baked into the premiums of any licensed plan is fees as a licensed plan to support appropriate oversight and regulation.
And the same is true on the CDI side. The premium tax will be applied to all new policies sold, and CDI can use those resources if they want to beef up their network evaluation operation.
And so it is a very good question regarding our not duplicating and having our service center refer the right calls to the right places, and it's one of the other things we'll be working on. So thank you for that.
Peter?
Yes, please, Kevin.
If I can have a board member prerogative and ask a question.
Please.
Before we move on to the next segment. I wanted to go back to what Andrea was saying about the adequacy standards and evaluative mechanisms in place, and the extent to which the geo-access reporting enables us to all understand network adequacy by provider type. And specifically, I wanted to ask a question about essential community providers or safety net providers. I was struck by Jeanette Lopez's comments to the board at our meeting last week about how Mr. Mibb, when it created the Healthy Families program, went beyond DMHC and CDI's network adequacy standards and incorporated some in-house monitoring, evaluation, public reporting, et cetera, in part to gather more detailed information about safety net provider participation. So can someone say something, or maybe this is something we can come back to better understand what information is gathered using CDI and DMHC mechanisms that can give us insight, not just to network adequacy broadly, but to safety net provider inclusion specifically?
Well, so there isn't any statutory or regulatory authority that currently exists in the Health and Safety Code or in the Insurance Code that would authorize either of those regulators to require a QHP bidder to do a geo-access or mapping style report showing evaluating the essential community provider network. That's not to say that they couldn't have that authority. That would have to be done through interagency agreement between us and the regulators. They don't currently do that. Now, we are going to, embedded in our recommendations to the board regarding essential community providers, is to require reports from the QHP bidders to demonstrate their geographic network sufficiency of essential community providers. So right now we aren't really contemplating having the regulators do that for essential community providers, but that we would perform that function ourselves.
Which would require us, and it's one of the areas that in particular, and we're about to move into that section, we'd like comments from plans, providers, and others, how best to do that. Because the issues around measuring sufficiency and sufficient participation is not a simple question. But it is an area where we would not rely on the regulatory standards unto itself, because it is an area where the exchange is absolutely, by both mission and legal charge, going above and beyond the standard regulatory minimum. So assuring that there are sufficient safety net, essential community providers is exactly what we're about to move into in terms of the next part of the discussion.
Right, so just as a reminder, non-QHP are not subject to any requirements regarding inclusion of essential community providers. This is unique to qualified health plans. So
Kim, did that address that? Can we come back to that a little bit as we go through the next part?
I think it's a good transition in the next set of issues you're going to be presenting. Thank you.
That's great. Okay. Thank you, Kim.
So let's move to, there's 3 different issues in the essential community provider brief, and they are definition, how we determine geographic sufficiency and distribution of essential community providers, and the third and last is payment to FQHC. So these are interrelated. At least 1 and 2 are very, very tightly interrelated. Before you can figure out a mechanism for measuring geographic sufficiency of distribution of ECPs, you have to define the animal. What constitutes an ECP? So we took that task on first, and between I kind of dubbed these the narrow option versus the broad option. The narrow option would be to limit the definition of essential community providers to those who are on a federal list called 340B. And 1927, these are straight out of the Affordable Care Act. 1927 is a section of the Public Health Service Act. And the Affordable Care Act requires these providers to be included, but it gives the exchange the discretion to build upon those 2 lists. And that is exactly what we're recommending, option B, which is to adopt a broader definition of essential community providers to include physicians, clinics, and hospitals which have demonstrated service to the Medi-Cal, low-income, and medically underserved populations. Now, just before we move on to the next issue, let me say a little bit about why we're advocating a broader definition than simply the 340B and the 1927 providers. First, we found through meeting with provider groups and advocates of all different types, including, say, the Chronic Care Coalition, that there are certain subsets of the low-income population that tend to go to private practice Medi-Cal providers and doctors more than they do clinics. and they are the low-income they are a part of the low-income population. There are also a subset of providers who have essentially dedicated themselves and set themselves up to serve the Medi-Cal population, and they are not. Many of those providers are not on the 340B list. And some of those providers are participating in local initiative plans that we hope will be enticed to submit a QHP bid to be part of the network. And many of those clinics in some of those local initiative plans are specifically designed to serve a certain cultural and linguistic population, and we really don't want to leave those clinics out.
Andrea, I'm going to ask you to speak to the standard of sufficiency as well, because they are, as you know, very linked issues, and then we'll take the comments, okay? Sure. And then we'll hold the payment of FQHCs as a third distinct area.
Perfect.
Okay, thank you.
Perfect. So turning to the next question, which is the sufficiency, I want to say at the outset before we go over a current recommendation that one thing we're considering right now that we would really welcome your feedback on is proposing a separate sufficiency standard for hospitals and non-hospitals. We didn't do that initially, but the more time our team has had to reflect on this, the more we're thinking, wow, you don't go to the hospital that much necessarily, but you do go to the doctor or the clinic more often than you do go to the hospital. So it's probably a better idea to have two different sufficiency standards. So certainly welcome comments on that. Our starting point, however, was to recommend option B. Well, first let me say that there are no time and distance, some metrics out there, right? There are no quantitative sufficiency standards for essential community providers. There isn't anyone who does this anywhere. So we're kind of figuring it out for the first time, if you will. Option B is what we're recommending, and it's an overlap analysis requiring a QHP bidder to come in and show us their essential community provider network as a subset of their overall network, and do that in relationship to where the low-income population in the regions that they're proposing to serve resides. Now, in the brief, we did suggest a definition for what constitutes a low-income population, and I think we put in 250% of federal poverty level or below. We are also considering modifying that to 200% of federal poverty or level or below, because that is a federal standard, I think, used in the HITECH Act. And so we at least have some reference point for another currently accepted federal definition of what the low-income population is.
That 200% is also the figure that's used for where cost-sharing subsidies are paid under the exchange enabling legislation in the Affordable Care Act. Okay, so we turn to comments?
Sure. So we got two things, defining the low-income population at 200% or below and having separate standards for hospital and non-hospital, and reaction to that plus anything else you want.
Okay, so I'm going to go through and read off some of the comments and questions. First, from Maureen O'Hara, who represents Molina Healthcare in California and American Family Care, the affiliated medical group, notes that Molina strongly supports a broader definition of essential community providers, notes that American Family Care operates 18 primary care clinics in 4 counties that serve the uninsured at a significant discount off the Medi-Cal rate, as well as Medi-Cal, Healthy Families, Dual Eligible Medicare, etc. American Family Care is not a 340B or 1927 provider, but has made a significant investment in serving underserved communities. In addition, from the health plan perspective, this is again Maureen speaking, you can tell by her tone of voice, from a health plan perspective, a narrow definition of ECP would be problematic because many of these providers may be fully to capacity and can't provide timely access. Mandated that plans contract with a small population of public providers also inhibits competition on quality and access. Thank you for that comment, Maureen. For all of these, I do encourage people to restate your comments in writing. We have some board members with us today, others at other times, and board members really do read through all the comments. Next is a comment from Ann Donnelly. We urge the exchange to consider HIV experienced providers in the definition of essential community providers. People with HIV who are in care will need to purchase coverage in the exchange in the first year due to the Ryan White program payer of last resort requirements. So the population of people who will need access to an HIV experienced provider will be roughly estimated for the first year. Given the importance of health outcomes for people with HIV getting care from experienced providers, we believe there will need to be some standards of access. I think, again, this is a great comment. I will also note, and as many people know, I cut my teeth early on in the epidemic working on HIV issues and pre the founding of Ryan White. It raises a challenge, is that to have defining essential not by income level but by who's getting service is a challenge not just on HIV, but that this issue could be raised for other particular types of care of having, do you have enough providers of particular types? So I think it's a very important comment. We'd relish getting that in writing. How would it be operationalized? The definitions we put on the table are framed by income, and that's the dividing line. And I think many, many people with HIV are seen in community clinics, are seen by what would be defined as these essential community providers, but we'd welcome comments on how that might be operationalized. You know, we are committed to making sure that everyone in the exchange with the whole range of medical conditions gets access to the right care from the right provider at the right time, which is one of the elements that's being sought to be addressed in essential community providers, but there's other elements as well. So there might be other pieces of our policies that would get to that. From Elizabeth Goodman, will a list of essential community providers be made public? If so, when? And I assume what Elizabeth means here is a list of the types and definitions, not the list of specific organizations. And I think it is our intent, and Andrea's, that for what's going into the board in August 23rd would include a clearer list of when we say here's the types of organizations, so people can see, oh, that sort of organization is on the list, that sort is not. That is broadly spelled out in the brief itself now, but we will make sure it is clear for comment going into the final recommendations brief to the board.
Okay.
From Rachel McLean, would the exchange consider including alternate sites where injection drug users typically access care, such as syringe services programs, mobile health vans, and narcotic treatment programs? Research has shown that injection drug users typically receive all of their primary care and preventive service needs in these settings, and due to stigma and other barriers, do not feel comfortable accessing healthcare services in hospitals and clinics.
Well, that's a very interesting comment, and I think we need to look into that more. I can think of a couple of clinics that I'm aware of in Sacramento that might meet that definition, but it's unclear to me whether you're still talking about brick and mortar here. I guess a mobile health van.
These are bricks and mortars with wheels.
Right? Yeah. So I think we need to research that a little bit more. It's very interesting.
It's a great point. And
great comment.
They may be covered by, my guess is, but we don't rely on guesses as an evidence-based organization, is that many of the clients of those providers would be absolutely in the 200% or less of poverty. And so as providers, we need to look at issues of, is it bricks and mortars that limits, or is it the client pool? But it's a great flag. We appreciate it. We'll look into it.
Yeah.
Next comment up, which is from Dr. Gilbert Simon, is how will you determine if a provider group participates in programs for low-income groups to a significant degree? And this is a very good question. If we say that it needs to be 20 or 30% of a clinician's population is low income, how will we identify that?
Right, and this is something that we're going to have to decide before we complete the solicitation, because we need to give instructions to the QHP bidders how they are going to go to their networks and ascertain, and beyond the black and white of are you or are you not a 340B or 1927 provider, if we have if the board adopts a broader standard and includes other types of clinics and doctors and clinics who serve Medi-Cal, for example, or healthy families, the QHP plans are going to have to be able to identify those folks, tag them in their provider database, and put them on their ECP list. So they're going to have to reach out to these providers somehow and make a determination of whether they qualify under the definition of essential community provider. Isolate those providers in the database so they can do the types of analyses that we're going to be requesting in order for them to demonstrate geographic distribution and sufficiency.
And again, we recognize that if any providers are under stress, it is these providers who are providing care and services to people on Medi-Cal and low-income people. And we want to develop programs that don't add burden on them as to participate in the exchange. And so we want to look at issues of how do we make sure that we make this as easy as possible for those clinicians, which may be in partnership with DHCS or with others. So, and again, this is an area where we have a path. We need your counsel and assistance, whether you're a provider, a health plan, or others. Say, here's a way we could do it that could make it easy. Okay, easy and right. So it's not, easy is not the end point. Easy and right. Okay. A next comment from Sandra Barr is, given that some physicians are already refusing to accept Medi-Cal, healthy families, et cetera, what will be the incentive? I want to note that this is a meta question beyond the scope of the exchange, which is, and I will do a quick sales point, if I may be so bold, for the Affordable Care Act, recognizing the challenges of Medicaid programs around the country that actually has a provision that for the next 2 years, Medi-Cal providers doing primary care will be paid at Medicare rates. That's a very substantial step up. It provides a substantial incentive for more involvement of primary care providers in the Medi-Cal program, which we think is a very forward-thinking thing of the Affordable Care Act. The exchange, so to speak, it's not our job relative to the Medi-Cal program. We want to make sure that low-income individuals who see providers have the opportunity to continue seeing those same providers however they're paid. So I think Sandra's comment is a good meta comment, issues the state is wrestling with. The exchange sits in a particular piece there. So I'm going to pause for a moment. We have another number of other people queued up, but I do want to remind both Kim and Dr. Ross, who is on the line with us, if either of you have additional comments or questions, we welcome those. And again, I know that we have more than 120 people on this call, but I've said it before, I'll keep on saying it. You folks out there throughout the state should recognize that our board members are not glamorously overpaid with mammoth shares and stock options. And I really cannot appreciate too much the time that Kim, Bob, and other board members play preparing for meetings, doing these sorts of sessions, and engaging with us. So Bob, again, both you and Kim, thank you.
Peter, this is Kim. I don't know if, I think Bob may be in a listen-only mode.
I think he is.
He's in some undisclosed, very noisy location.
Okay, so
maybe, are you there, Bob? No. Okay.
Undisclosed, very old. Okay, so we make
so maybe I'll ask a question or invite our staff colleagues to respond to a question that Bob raised very briefly in our last board meeting, and then I have a question of my own. And one of the things Bob had requested, and I'm confident we'll hear more about it at our next board meeting, but maybe for purpose of this call, is just to hear a little bit more from our staff colleagues about some of the considerations, both on the upside and concern side of the broad network or the broad definition of essential community providers versus a narrower or more focused definition. So if someone could just talk a little bit more about some of the trade-offs and considerations there. And then a related question I had was, how do we think about these definitions of essential community providers in the context of our broader discussions about qualified health plans and the possibility of rather narrow network products? So those are two. Number one, pros and cons of the ECP recommendation around definition, and then secondly, the relationship between the broad definition recommendation and narrow network products.
Great. So I guess this is Peter. I'll take at the meta level, but I'd welcome either Sandy or Andrea or Leah to chime in. The big issue when you think about broad versus narrow is the more narrow the definition, the more, in essence, you give a strong boost and a leg up to those entities which are often at the core of the safety net. So you look at 340B and other providers, a more narrow definition means that those entities have more leverage with the plans that we're contracting with, have more ability to be in bigger numbers. So that's the advantage of a more narrow definition. It gives leverage to what are often core and very vital parts of the safety net. The advantage to the broader definition is when you look at where consumers go for care who are low income, it isn't defined by the more narrow definition. It is many, both Medi-Cal and low-income individuals see individual doctors, for example. And so the issues of reflecting where people go in the broader definition allows both for more flexibility of plans, but in essence, a little less leverage of the providers because of the bigger set of those that might be defined as essential community providers. And I do want to note Andrea's question early on of having two tranches, so to speak, to evaluate essential community providers, of separating out hospital from outpatient is important because it is different. Outpatient care is different from hospital care, and I would bet dollars for donuts we will come in with a final recommendation that have different standards for those two, but then even within the outpatient, that's where it tips for the broad versus narrow. Does that make some sense, Kim?
Yeah, no, that's helpful. And then how
the narrow network issue? An incredibly good question, and quite honestly, I'm not sure. The standards we will have, and we will be, we have said within our network design writ large, we anticipate plans will be coming in with not just everyone in networks, but with more narrow networks that are going to be based on value equations of higher quality, lower cost providers. My bet is that essential community providers would very often be in the quote-unquote sweet spot for who plans would be contracting with or seek to contract with as narrow network providers, because they are very often providers that have learned how to be efficient, deliver care more efficiently but with high quality. So, but it will be our job to say, even on a narrow network, you must meet our essential community provider standards. And so that will be an overlay that we will have, whether it's a broad or a narrow, under either circumstance.
Yes, I agree with it. We certainly do not have any, we don't have any ability to waive the essential community provider network requirement for a narrow network product. So they will absolutely be required to include. And to Peter's point on the sweet spot, I would also say that many of the essential community providers are already, we've been told, working very hard on delivering team-based care and having patient-centered medical homes. And those are some of the strategies that we're going to talk about next week that the QHP report recommends to the board that we look at and place value on in our selection process. So if you have an essential community provider who has developed an efficient delivery system model, and that includes a patient-centered medical home, they will be adding a great deal of value to a QHP bidders network by fulfilling multiple criteria.
So I'm going to now read off a couple of comments received, and again, we can't thank you enough for all of you joining us. So first from Gilbert Simon, noting that 340B and 1927 providers account for less than 20% of the care to Medi-Cal recipients in Sacramento County. The county sees a smaller number, but the lion's share of services are provided by traditional Medi-Cal providers who will be excluded from the narrow option. Now, on the similar comment is from, no, I saw it there a moment ago. We'll come to this next. Okay, is two comments about sufficiency, or a number, which is first, Megan McGammon, noting the regulations read that ECPs are those who care for, quote unquote, predominantly low-income, underserved populations. According to Merriam-Webster, predominant means greatest proportion, most common. Is your reading that predominant means 51% or 30%? And another comment from Sarah Mueller is we encourage the exchange to establish a minimum sufficiency standard to ensure ECPs are included in QHP networks. Specifically, we recommend a streamlined approach to ensure a minimum of 50% of QHP's primary care network be comprised of essential community providers. I'm sorry, those aren't the same topic. I thought the 15% was about the minimum. So I'll go to Megan's point. We are absolutely looking at predominant, not meaning 51%, but meaning, I believe we are looking at 30%.
Right. We are referring to the California Healthcare Foundation report, which I might ask Leah to comment on, that found that Medi-Cal providers, CCPs who have at least 30% of their practice as Medi-Cal, 30% of their patient mix being Medi-Cal providers, are committed as being traditionally providing services to Medi-Cal. And that's 30% for PCPs and 20% for specialists. We are not taking a literal definition of, like, dictionary definition of predominant. I mean, that may be technically one approach, but we're really trying to implement the spirit of the Affordable Care Act, which is to call out essential community providers as a special type of provider, and to make sure that our patient population has access to those types of providers if they want to continue to use those types of providers. I think one question underlying this entire discussion is that people will definitely want to go to the exact same provider they've already used. Now, they may want to. They may want to try some other type of delivery system as well. And certainly, once they have coverage through the exchange, they'll have the freedom to do that. So that, I think that addresses that. The comment that Gilbert Simon makes, I think, is a very compelling picture of how Medi-Cal patients are served in the state of California.
In one county. I want to note that speaking to Sacramento, and this is where we recognize, and this is what in the exchange has sought to articulate consistently, is healthcare is local. And that mix is different in different counties, and yet the exchange needs to make policies that are statewide and recognize and are sensitive to local differences.
Right, and we have looked at other counties. We looked at San Diego County and found.
This is Kim. That might be helpful, and you're absolutely right, Peter. You've seen one county, we've seen one county, but to the extent, and I also agree with Andrea that Gilbert's data is really very interesting. To the extent we have that on a broader statewide basis across all counties, I think that would be helpful information for the board.
We'll seek to provide that to the board. We'll have that as an appendix for the next brief. Will be 390 pages. Just kidding, Kim. I'm not going to. And I will note that Dr. Ross has been able to be unmuted. If Bob, if you have a comment or question you'd like to weigh in on, well, before going back to the big board.
Thank you, Peter. Actually, Kim did a very nice job of anticipating the question that I had, and I would say please proceed. Thank you.
Great. Thank you very much for joining us again, Bob. So I'm going to go to and this is from Sarah Mueller again, is I have two questions. First, California already has standards in place to define providers that have a mission to serve underserved populations. Why can't the exchange build on this existing framework that includes niche hospitals, community clinics? A high volume should be established for other providers, showing no less than 50% of all costs associated with providing care for Medi-Cal, uninsured minimum of 10% uninsured. This is exactly, again, where we relish your comments. We have recommended that we build on existing standards, such as 340B, definition of dish, and then have volume standards. And again, the 30% of the patient load is what we're looking at for your reaction to finalize recommendations for the board. We need to have recommendations that to our board, which are actionable, that are operationalized, can be operationalized. And so we understand your comments there, appreciate them, and encourage you to continue to weigh in.
And I would say operationalized in a way that doesn't kill the desire of plans to bid as QHPs. I mean, we need to realize that this is a requirement that only qualified health plans will be subject to, and it needs to be something they can actually do.
We have a comment/question from Brett Johnson. Like Molina, the California Medical Association supports the broader definition of essential community provider. If the exchange will be utilizing additional geo-access reporting data to gauge sufficiency, will this information also be used to enhance provider search functions for enrollees through the exchange website, e.g. by language capacity? I think it's a great suggestion. One of the elements that you may all be, and this is where, Brett, I appreciate the comment where it underscores that everything's connected. The enrollment system we will have through CalHERS, the California Healthcare Eligibility Enrollment System, we have a desire to have a provider directory. We want that provider directory to identify important issues around culture and language. So to know if this provider speaks Spanish, speaks Hmong, speaks Mandarin, and if so, which plan does she have a contract with? So you can know when you want to contract with Dr. Ramirez, who speaks Spanish, she has contracts with these 4 health plans. So that's certainly our ambition. We would seek to do that, and I think it raises a very good point that sufficiency standards don't get patients in the door to see the doctors they want and need to do, which is other work we need to do, and that we look forward to doing. Next question from John Weiss. How will you ensure that there is not adverse selection if you'll be using old self-reporting for health plans on network adequacy? As a plan, I could exclude or reduce the number of oncology providers so the members would be swayed away from my network for those conditions and allow me to design my network to avoid high-dollar procedures. Well,
I mean, first of all, the regulators, one of the things we're talking about was there seems to be a lot of concern that QHP bidders are going to be putting forth network analyses based on doctors who are not actually in their network. One of the an easy way around that is to require the QHP plan when they propose the network to submit a legal adaptation that, to the best of their ability, the network reflects providers with whom they have active contracts. In terms of getting down to the oncology level, as I noted earlier, the network criteria, the network buckets right now are primary care, physicians, specialists are lumped together generally, and then mental health is also broken out. Hospitals are also broken out. So the way we would know whether or not the adverse selection that you discussed on oncology providers is some type of analysis. It would have to be on a kind of a problem-oriented basis. I don't think that it's practical to have QHP bidders submit a geo-access report for every single category of specialists. I mean, I don't think that's practical.
So let me do and I want to note another thing, if I could, to John. This comment is obviously jumping back to the issue broadly of network adequacy of not essential providers, which is great. We take comments on all these topics. But the other thing I'd remind John and everyone is, come 2014, the rules have changed. I say this a lot. The health insurance market writ large, individual, throughout the market, exchange, non-exchange, is designed to, and we'll see how successful it is, to not be about gaming your population. There's going to be risk adjustment and risk assessment. So if that plan, through whatever mechanism, tries to get people without cancer and disproportionately succeed, that plan is going to be paying the plans that have more people with cancer in it. And so the risk adjustment, risk assessment process is designed to move us from a health insurance world, which is about avoiding risk, to being a health insurance and a healthcare marketplace, which is about the 3-part aim of better care, better health, and lower costs. I'll get off my soapbox. I want to actually pose a question, if I could, while we go through some other comments for about 7 more minutes, then we're going to move to the payment for FQHCs, which is this issue of I articulated, or software articulated, the pros and cons of the narrow versus broad definition of essential community providers. We've had a number of individuals that I've spoken to who have all spoken to the preferring the broad network, not broad network, the broader definition of essential community providers, and we have not heard from those that are supporters of a narrow definition. And I would actually encourage, if there are supporters of narrow definitions, to state that, because again, part of what we're doing in these webinars is we want to listen to each other, to hear each other's arguments and points of view. Now, of course, you can put it in writing, you will put it in writing, but Dr. Ross specifically called for those that have that view, say the rationale of having a more narrow definition, the strong benefits of that kind of definition. We'd welcome that. So while people are busily typing those comments in, I'll go to Karen Meng, who notes that doctors of optometry have historically been Medi-Cal providers. Historically, 85% of optometrists have participated in Medi-Cal, yet the current HMO systems exclude optometrists from providing medical eye care. Are you considering regulations to address this issue?
Well, I'm unaware of regulations that prohibit an HMO network from including optometrists. So I would want to check on that first. But I do want to preview to the group that we are actively considering an express requirement that optometrists be included as a network provider in both PPO and HMO networks, specifically so they can, the QHPs can be assured of having eye care specialists to provide the pediatric essential health benefit for vision care. So I am unaware of any HMO regulations that prohibit HMO plans from including optometrists, and I will certainly check that, but I myself have used an optometrist in an HMO.
I think that the question, I think, is should they be required to?
Oh, okay.
And so that's an issue of regulation, but from our perspective, we will require there's adequate providers in our networks, optometrists and others, to serve
adequate optometrists.
Exactly right.
Yes.
Okay, we have from, and in specific response that was actually queued up before to Dr. Ross's comment from Tina Kim with the Community Clinic Association of Los Angeles, a number of comments which are very helpful. First, she notes that the discussion of what is predominant is a slippery slope. Is those primary care providers that serve 30% of Medi-Cal beneficiaries are not subject to see the large patient mix of uninsured compared to the true safety net providers. She also notes that under the definition of 340B and 1927C providers in the brief, it says further federal regulatory guidance is expected. Has the exchange received any indication of when that federal guidance would come? Tina, I hate to tell you, having been a Fed, what we generally hear is soon, and unclear when. So unfortunately, I can't predict when that's coming. And I do want to note that Tina notes that her question about the, with regard to 30% safety net, the core safety net providers that may have 80% or more, it's different than if you're just doing 30%. And so that's a concern for the slippery slope, which is noting their support for the narrow definition. So thank you, Tina. Now we have a number of comments from Megan McCammon, and we're going to do these, and then we're going to turn to the payment issue on SQHCs. And so the issues first, the way that option B is written makes it sound as though it requires only that a plan shows some amount of overlap between the QHP network and a Medi-Cal network. But when Andrea presents it, she sounds like it will depend on an analysis of low-income populations. The statement and words seem to disagree. Andrea, do you disagree with yourself?
I try not to. But thanks, Megan, for that, and we can talk offline to follow up on that a little more. When you do a mapping type of analysis, you do need to have two technical components. You need to have your provider network and enter those into your software, and you need to have your target population. So we are proposing, we have been kind of struggling with where to draw the line at who constitutes the low-income population. I think, as I mentioned earlier, we would be setting at, say, 50% of the census tract it reflects population of 200% FPL or below, that would be considered a part of a low-income population. So that's what we're looking at right now, and it would be a overlap or mapping style analysis to see if the ECPs tracked to the low-income population.
So we're going to go to one last comment here, and then we're going to go to FQHC issues and payment, which is again from Megan. Similarly, the expanded definition of ECPs, QHPs can select against contracting with traditional safety net providers who do see predominantly dictionary definition, low-income populations, who tend to be older, sicker, with more chronic conditions and less health literacy, and that community clinics and health centers certainly prefer a narrower definition. We, being community clinics, are concerned that given a broader definition and the ability to meet sufficiency without working with community clinics, qualified health plans would or may choose not to contract with community clinics and other traditional safety net providers who see huge numbers of not just Medi-Cal but the uninsured poor, and noting that community clinics see patients that are significantly older, poorer, sicker again. So that again, I appreciate that. Those speak exactly to some of Bob's questions. I wanted to hear sort of balanced voices, and we've heard comments on both sides of that issue, as with many. The exchange uses are not just thread the needle, but address balancing acts of non-perfect answers in an imperfect world.
Right.
With that, I'd like to turn it to the FQHC payment issue. So with that, it will, Andrea,
okay.
turn the FQHC, we'll come to the other issues then. Okay?
Okay. The Affordable Care Act does, and recent federal rules, proposed federal rules, addresses the question of federally qualified health centers. And so we analyzed those rules and concluded that the rules give the exchange the discretion on making any type of policy decision regarding payment to federally qualified health centers. So I think most folks are familiar with the three options that we looked at: whether to require QHPs to contract with FQHCs and mandate the terms of payment, whether to encourage inclusion of FQHCs in QHPs and mandate the terms of payment at the PPS rate, or option C, to encourage the inclusion of FQHCs in QHP networks and require the compensation, the payment by the QHP bidder, to be fair compensation defined in the rules, in the federal rules, as no less than the generally applicable rates paid by generally applicable commercial rates paid by an issuer in the area. And we are recommending option C. And I might add that that is something that we can, in implementing this through the solicitation, we can certainly require a QHP bidder to point out to us in their response which FQHCs they have included in their network, which would mean that they have achieved the goal of providing fair compensation because they have a contract with that FQHC. We can certainly take a closer look at that while we're evaluating responses to the solicitation. So all of the policies that are going to be actually implemented are not necessarily here. There are still some finer grain ones that we can apply as a condition in the solicitation.
And with that note, this is again where your comments and suggestions, with as specific as possible, are helpful. And I want to note that the board and staff very much recognize the vital role that the safety net, the community health clinics play. I'd like to, I'm not speaking for, but somewhat in this way for Dr. Roth and Ms. Belcher, when they said for the board that the vision of the exchange is a vision in which all Californians get access to needed care, was a recognition that we are part of what is still a frayed fabric of care in California. That doesn't mean the exchange can be the be-all and end-all solution to that frayed fabric. There's a lot of other issues in play, but there is a recognition of that. And I think that we'd welcome specific thoughts or suggestions that might encourage QHPs potentially with a broader definition, but other encouragement to contract with FQHCs, which are vital. So we welcome those suggestions. We will be coming back to the board with final recommendations, again, after we get comments between now and August 6th. So with that, I'm going to turn to a couple of the other comments we've been receiving. And now we welcome comments in particular on this issue, but also if you've had comments welling up on some of the other issues, we welcome those as well. So we have a comment from Kristen Spalding, noting that while I've not formulated an absolute position on the broad versus narrow definition, it seems to me that the narrower definition encourages QHP bidders to include the traditional safety net providers in their plans. Ensuring that the safety net providers are participating in the exchange will ensure or help ensure the viability of safety net providers who must serve the uninsured and will serve those who go on and off eligibility exchange. And I think Kirsten noted that the strength of the more narrow definition relative to those vital providers, we've heard arguments for the broader, but I think that's a well-articulated point. We have another comment, not specifically on the issue of payment, but on the issue of narrow networks, which is, and this is from Patrick Pine, that notes regarding narrow networks in more urbanized areas, I think that it makes sense to consider, but in rural areas, it's generally not an option. There's a lot of evidence that big price variation in the same communities, such as the Dartmouth Atlas work. I'm not sure how to address this, but this is clearly an issue. Similar experience with pharmacies, substantial evidence that a narrower network can have noticeable cost and price benefits. And I think Patrick, to my experience and knowledge, which is not insignificant, is spot on. Is that the issues on narrow networks, where you're in LA, where you're in San Diego, it's very different than when you're in Tulare. It's, there's network challenges right out of the gate in more rural areas, and so we will be looking at this at what networks are brought forward by our qualified health plans. Is narrow means, again, one thing in a rural area where we probably need virtually every provider we can have in many of the plans that are there, as opposed to in urban areas. So I think, Patrick, thank you for your comment. It's certainly something we'll be looking at. So we welcome folks' thoughts or comments. I don't want to put our board members on the spot. Do you have any questions about what we're wrestling with on this issue, Dr. Ross or Ms. Belshea?
This is Kim. I had a suggestion or a thought for some additional research and learning, and it's in the context of our state's experience with the community provider plan through the Healthy Families Program. And for those, I think people are generally aware, but the idea is that there's one plan designated in each county as a community provider plan, and they're so designated because they have provided the largest percentage or have done, as they characterize, the best job of including traditional and safety net providers in their network. And a plan that's designated as a community provider plan is offered to enrollees at a discount. I'm not sure. I think historically it's been about $3 a month to subscribers, but it might be helpful, Peter, for us to kind of spend a little bit of time with our Mr. MIB colleagues and see what, if any, research has been done on that experience, because it seems to put a very strong incentive, to the extent this is a price-sensitive population, that it puts the incentive on, creates a financial incentive for our QHP partners to do a good job very proactively in terms of identifying and engaging and including in their provider networks essential community providers. So it's an example of looking at contracting strategies to help advance some of these broad policy goals around the inclusion of our safety net partners.
Great, Kim. We will absolutely look at it. We've done some looking on that already, but we'll look at it some more and bring that back to the board and how that's informed or may affect our recommendation. That's great. Thank you. Other? Oh, go ahead, Bob.
Peter, can you hear me?
Yeah, we sure can.
Can you hear me?
Yep.
Yeah, so back on the question of payment rates, we get QHCs, and the assumption here is that cost is the issue here, cost to the plans, cost to the premiums, cost to the exchange. I'm wondering, are you aware what Massachusetts does in terms of
yeah, Bob, you cut out a little bit. Aware of what? Who did what?
Massachusetts.
Massachusetts.
what Massachusetts is doing on this issue, or any other of our pace-setting states, Maryland or others that are near or at our stage of development, or whether anyone has decided on how they're moving on this issue among options A, B, and C.
Well, we are aware on the hospital, Dr. Ross, but I think we do need to contact Massachusetts or ask our consultants to help us and do a little research on what they do with respect to non-hospital essential community providers. We know that in Massachusetts, the standard is one hospital per region. One essential community provider hospital per region is required. So it's a pretty sparse hospital standard, but we don't know what they do on the non-hospital providers, and we can certainly look at that.
We will, and I think, Bob, if I may, we will take this as one of our charges to include in our brief on this, and we might look at it in other areas. We are a pace setter, California is, and so many states are looking to us, but insofar as Massachusetts has had to deal with this already, and we will do a quick poll of the other pace setter-like states, Maryland, Oregon, Washington, and we'll touch base with them. And we have a comment right here. I love this. We won't tell you her email address, but we have the Maryland Exchange is on the line with us listening. Tequila Terry would love to connect with us on this topic, and we'll explain what they're doing. And I will note that we have people from around the country listening to these webinars. Thank you, Tequila. So we won't give you out everyone her email, but we appreciate it. She also gave us her home phone and what her social security number is, which we won't also publicize. Bob, we will follow up not only with Maryland, but with the other states to see what others have done. We want to be evidence-based, and others are wrestling with the same challenge. And it is, as you know, the good news, we believe, it may not be perfect, but the requirement that QHPs that contract with FQHCs can't lowball them. It is a must pay them what they're paying other providers for similar services. That isn't saying they must pay them the PPS rate, which is a rate which is specifically structured to recognize that FQHCs serve the uninsured. And that, as a matter of policy, is a subsidy to help cover the uninsured as a matter of public policy that we support. This recommendation is saying the exchange to require our plans to pay that would be having that be loaded onto our premiums for low-income individuals. And this is a really tough place that we're in terms of looking at recognizing the role, the really critical role that FQHCs play, and where do we stand with our low-income, relatively low-income people supporting that. Do we have other questions or comments on this issue? We have none right now. I'm going to foreshadow the next slide, if I could, which is while we have people see if they have any closing comments, we feel okay ending early. It happens so rarely, we don't mind doing it. This was a very focused webinar on a very relatively small set of issues. We did not get through all the comments on the earlier webinar, and I would bet you dollars for donuts we don't on the next one. So you can bank the time, so to speak. But I want to reinforce what Andrea said at the beginning, which is, first, underneath these PowerPoints is a 263-page document. The section on provider adequacy, essential community providers, FQHCs is itself 40 pages. We've given a lot of thought into this. We don't think we've got it all right. We need your thoughts, suggestions, and comments. We need you to weigh in and provide additional thoughts, and I cannot encourage you enough to be as specific with your recommendations as possible. We are moving quickly. We recognize that. Part of moving quickly, though, is to have dialogue such as this, to have engagement such as this. But the more specific you can make recommendations, the more actionable it is for us, the more it helps our board. Number two, as Andrea noted, there is a stakeholder input form on our website. It helps us to use that, but don't feel boxed in. We give every single comment we receive to our board. I know our board reads them. I know our staff reads them. And I will note, having been for 2 years a Fed and now having been a person in the state, your comments make a huge difference. They are read, attended to by staff. They matter. Your time here matters to us. So when you spend the time to weigh in, we do listen. We appreciate it. Finally, we do encourage you to provide comments by August 6th. We need to digest a lot of information. We're moving quickly. We're trying to do it as thoughtfully as possible to turn around material both to our board and to you so you can see the final recommendations and then weigh in advance and weigh in on those issues. Okay? So with that, I really do want to appreciate everyone joining us. We had over 120 people who joined this call. Many of you weighed in with comments. I want to, again, strongly appreciate Bob Ross and Kim Belshea taking time out of their busy schedules, as you do every day of the week currently, serving on this highly paid board to help shape the healthcare system for California and make it affordable and available to millions.
Peter, you have to stop saying that, because some people are just going to get a snippet of that, and that will be the story, that we are a highly paid board.
It'll be tweeted. Peter Lee accuses board of being highly paid. Yeah, they get nothing. They get a stipend is less than it. So I will be careful with my attempt at humor. But I do appreciate your time joining us, and I will remind you that on August 1st we will have another webinar. That one starts bright and early, 8:30 in the morning. We'll go until 10. And thank you all for your time. And if we don't talk to you before then, have a wonderful weekend. Thank you for joining us.